Thank you, Raja, for joining us here. Raja is the current head of transplantation in Minneapolis, USA. And Minneapolis is the place where the first pancreas transplant occurred 50 years ago. And we celebrated a few months back in Minneapolis the 50th anniversary of the first pancreas transplant in Minneapolis. And I was fortunate enough to be there. And so since in 15 years, we have seen a tremendous progress in pancreas transplant, and it seems that in the past years we are seeing a sort of plateau or even decline in the pancreas transplant activity. So my first question to you, Raja, is how would you explain that? What are the reasons, or what is the main reason?
I think, first of all, Thierry, it's a pleasure being here, and thank you for inviting me, and it's a pleasure chatting with you all, as always. I think pancreas transplantation has evolved, and it's followed a natural path of evolution. I think it started in the late 70s in earnest, and then picked up in the 80s. We peaked in the late 90s and early 2000s. I think there was a clearing of a backlog of patients. There were quite a few diabetics out there that had not been able to utilize this technology, and by 2000 we were able to transplant about 150 pancreases a year at the University of Minnesota for 3 years in a row, essentially clearing out quite a backlog of patients that were type 1 diabetic who did not have the opportunity to have their diabetes corrected. So past that point, at about 2004, the numbers started plateauing, and then we saw a steady decline in numbers. And the reasons are multifactorial. Part of it was the excitement of islet transplantation. There was a lot of excitement around the year 2001 with the Edmonton Protocol being introduced with great success in a small population, and therefore a lot of patients wanted to wait for the less invasive procedure, which has been postponed somewhat, but we are hoping will become a reality here with approval soon. There has been other issues as well. There's been a mortality assessment in pancreas transplants paper that was published in JAMA, which had a damaging effect. However, notwithstanding all those, the patients themselves have woken up to the fact that pancreas transplantation is here to stay, either as whole organ transplant or as islet transplantation in the future. And therefore, we are seeing the numbers pick back up again. In the last 3 years, we've actually seen stabilization. And for the first time in 2016, the US numbers have crossed 1,000, which is the first time in about 4 years. So I think the news is good for beta cell transplants.
Okay, so this is reassuring news. But in the previous years, what happened? In fact, did we see a better care for the diabetic patients, which made us have to face that fewer patients were actually in need of a pancreas transplant? Have we been also, from another standpoint, a little bit too picky about pancreas donor selection?
I think you more or less answered the question, because both of those factors are operative. Number one is there has been better management for diabetes with the advent of continuous glucose monitoring systems and more advanced pumps. And most recently, there's been a closed-loop pump that's been approved, a Medtronic device. So these are clearly things that have led to better glycemic control. Although the problem of hypoglycemia has not been solved. It still continues to be an issue. We've been able to get better A1Cs with the modern gadgets, but the hypoglycemic risk is yet to be solved. The incidence of secondary complications being decreased as a result of better diabetic management is hypothetical. I don't think it's actually panned out in the numbers. If you looked at the 2011 data on incidence of diabetic nephropathy over decades, they've looked at the last 3 decades, and the incidence hasn't gone down at all. Now, the reason might be that there's other problems like metabolic syndrome, obesity, and hypertension, bad eating habits, a sedentary lifestyle, which is now becoming more prevalent, that's offsetting some of the benefits in diabetic management, therefore causing the nephropathy effect to be the same. But I haven't seen the secondary complication improvement as most people claim. So I would say better diabetic management certainly was one of the reasons.
What about, so what you're hinting at is that there may be a deficit in referrals by diabetologists or by nephrologists or by both?
Exactly. That is a huge challenge, especially after the JAMA paper came out in 2004. There was a retreat amongst the referring physicians to refer for pancreas transplantation. It was felt that kidney transplant alone would suffice for diabetic patients with kidney failure and not put them through a pancreas transplant. It took a lot of outreach and education, and we are still working at it. I don't think we have completely recovered from that belief that has been set in the masses of referring physicians. Today's talk, for example, was to highlight the transplant options for the diabetic. Every insulin-dependent diabetic should be offered beta cell transplantation along with kidney transplant. If you're already buying into the risk of immunosuppression, there is no reason that you need to be insulin dependent after you receive a transplant.
Okay, I'm hearing you. So we're talking about the diabetic patients. So diabetics are not only type 1s, in fact they are a minority of these patients. What about type 2 diabetes? There is a lot of talk about transplanting pancreas to type 2 diabetic patients. Are we really doing that? Are we extremely selective? Can you comment on that?
Yes, this is a very relevant topic because the utilization of beta cell transplantation for type 2 diabetes is on the up and up. And the reason for that is this earlier onset of type 2 diabetes now. There's lean type 2 diabetes with severe insulin resistance, which physiologically behaves like a type 1. And the myth that insulin resistance is a contraindication for beta cell transplantation has been broken. In fact, the US allocation system now allows for type 2 diabetics to get the same prioritization as type 1s, provided they are not obese. Now, obesity is a modifiable risk factor, therefore, that's an exclusion criteria. So the lean type 2, which is BMI less than 30 in the US, gets the same priority as type 1. And last year's data shows that 13% of all simultaneous pancreas kidney transplants were performed in type 2 diabetics in the US. That's quite an increase from about 4 or 5% just a few years ago, so more than doubling of the amount, and I think it'll keep going up.
Okay, so but enlighten me a little, Raja, because what is a lean type 2 diabetes? Because I always thought that type 2 diabetic patients were rather on the chubby side.
Yes, that's the majority of them are. That was the fundamental tenet of insulin resistance, that fat tissue in excess promotes insulin resistance and therefore you became a type 2 diabetic. But that's only one mechanism of type 2 diabetes. Insulin resistance has a myriad of pathways through which it's mediated. And if it's mediated through obesity and fat deposition, clearly that's not a person you want to transplant. First thing you want to do is minimize the fat. And so what we do with our type 2 diabetics who are obese is we send them to weight loss management or bariatric surgery, depending on what's applicable to that patient. And if they're able to achieve weight loss and come down to a BMI of 30 or less, no longer can you blame the insulin dependence on obesity. At that point, they are a physiologic type 1, even though they're classified as type 2. You would think that should be a very, very small percentage, but in reality it's not, because long-standing type 2 that's induced by obesity does not resolve even after resolution of obesity. So they do provide a good candidate for transplantation, and that's what we've been doing, and I think it's a field that's going to grow.
So this is very encouraging, because we started this chat with a rather pessimistic statement, and we're ending it with the statement that in fact pancreas transplantation has brighter days ahead of it. So
I would tend to agree. I think what we tend to say is not specifically pancreas transplantation, but put pancreas and islets together and call it beta cell replacement. And if we put that field together, I think we have a future ahead. Maybe not forever, but for the foreseeable future, before other technologies do come in, such as stem cell therapy or an artificial pancreas, or even gene therapy. We learned about CRISPR technology this morning, gene therapy to thwart the autoimmunity. These are things for the future that might make us obsolete, but gladly so if they should become reality.
yeah, I agree with you. Thank you very much, Raja. Thank you.
Thank you.